Fidelity says a 65-year-old retiring this year will spend $172,500 on healthcare for the rest of their life. For a couple, $345,000. The number is wrong. It is wrong by a factor of 2 for early retirees who leave work before 65 and have to fund their own coverage. It is wrong by a factor of 3 or more for retirees who, in their 80s, encounter the long-term care costs the estimate excludes. The average couple believes they will spend $75,000 on healthcare in retirement, less than half of what Fidelity projects, which is itself less than half of what the back end of life actually costs. Today we walk through every age, 5 phases of retirement healthcare from 62 to 90 plus. Pre-Medicare years, where ACA strategy determines affordability. Medicare A and B years, where premiums and IRMA quietly compound. Supplement years, where chronic conditions begin to dominate. The long-term care window, where costs spike beyond what most retirement plans anticipate. And memory care, the final phase where care becomes constant and expensive in ways Medicare does not cover. At age 62, retirement begins for many, but Medicare does not. There is a 36-month gap before age 65. During this time, coverage is not automatic. It is assembled. Cobra can extend your employer plan, but at full cost, often $700 to $2,800 per month. The ACA marketplace becomes the primary option for most retirees. And here, income becomes the deciding factor. A 63-year-old earning $40,000 may pay around $300 to $400 per month for coverage. A retiree earning $90,000 may pay over $1,500 per month for the same plan. The difference is not medical, it is timing, income structure, and tax strategy. This is where retirement planning either works or fails quietly. A final year of employment, a bonus, unused vacation payout, deferred compensation, can push income high enough to eliminate subsidies entirely. The result is not a denial of coverage, but a sudden increase in cost of $10,000 to $15,000 for the same insurance. The strategy is not medical. It is financial timing. Roth conversions before retirement, controlled taxable withdrawals during the bridge years, and delaying income events that inflate magi. Not because it is clever, but because it is necessary. At 65, Medicare begins. Part A and Part B become the foundation of coverage. Part B starts at a standard monthly premium of just over $200, with an annual deductible layered on top. But Medicare is not uniform. Income-related surcharges, IRMA, change everything. A retiree just above the threshold pays more. A retiree far above it may pay several times the base premium. And the thresholds themselves are unforgiving. 1 year of higher income, reported 2 years earlier, determines today's cost. Out-of-pocket spending still averages several $1,000s per year, even with Medicare, and that figure does not include premiums for supplemental coverage, which many retirees rely on to reduce risk. This is also the decision point. Original Medicare with Medigap, or Medicare Advantage. One offers flexibility at higher monthly cost. The other offers lower premiums with network restrictions and potential future underwriting issues if you try to switch later. From 73 to 79, healthcare stops feeling like a system and starts feeling like a routine. Medication lists grow. Specialist visits become regular. Procedures that were once optional become necessary. A knee replacement, a cardiac intervention, a cataract surgery. These are not rare events. They are expected ones. Costs rise gradually, not suddenly. That is what makes this phase dangerous. Increases of 5 to 6% per year feel manageable until they are not. Prescription drug costs become a key variable. Even with caps, specialty medications can still cost thousands annually. Annual healthcare spending for a couple often reaches the high teens or low 20s in thousands of dollars. But the real risk is assumption, the belief that because the last 5 years were stable, the next 5 will be the same. Around age 79 to 80, the slope changes. This is the long-term care window. It rarely begins with a plan. It begins with a fall, a hospitalization, a short rehab stay, then a realization. Returning home is no longer safe. At this stage, Medicare coverage ends its usefulness. Medicare does not cover long-term custodial care. It may cover a limited period of skilled nursing after hospitalization, but not ongoing living support, and the costs are significant. Assisted living commonly runs tens of thousands per year. Nursing home care can exceed $100,000 annually. In higher cost regions, it can approach or exceed $200,000. Care at home is not cheaper. Full-time caregiving can exceed $80,000 per year, depending on hours and needs. This is where retirement portfolios are often drawn down faster than planned. A $400,000 portfolio can last years under normal withdrawal assumptions. Under long-term care conditions, it can be reduced to a fraction of that time frame. By age 85, the focus shifts again. Memory care becomes the dominant cost driver for many families. Dementia rates increase significantly with age, and care requirements become continuous rather than episodic. Facilities are secured, supervision is constant. The structure of daily life changes completely. Monthly costs often range from several $1,000s to well over $10,000. Depending on location and level of care. Over multiple years, total costs can reach hundreds of thousands of dollars, and in some cases, exceed $1 million. At this stage, the financial system matters less than the legal one. Powers of attorney, healthcare directives, and advanced planning determine what happens when decision-making capacity declines. Medicaid becomes the fallback for many families. Not because it was planned as the first option, but because private resources were exhausted along the way. Across all 5 phases, one pattern repeats. Costs do not rise evenly, they rise in steps, and the largest step occurs when ability to earn income has ended. The fidelity estimate captures part of this journey, mostly the early and middle years. It does not capture the end. And it is the end that determines whether retirement is sustainable or not. Healthcare is not just a line item in retirement planning. It is a timeline, a sequence of phases that behaves differently depending on age, income, and health status. Planning for it requires more than averages. It requires timing. How you bridge 62 to 65. How you manage income through Medicare brackets. How you prepare for the possibility of long-term care before it arrives, and how you structure legal and financial decisions before cognitive decline makes them harder. The real cost emerges in the years most plans assume will be stable, and the difference between those assumptions and reality is what defines retirement outcomes more than anything else. Next week, the variable that determines how much of every retirement dollar you actually keep: federal taxes, 5 income tiers, bracket interactions, and the strategies that shift retirees between entirely different financial outcomes.